to them. So Jean-Michel has been an activist fighting for the rights of LGBTQ people and people living with HIV for over 30 years. He began volunteering with the AIDS Project Los Angeles in 1989 and joined the organization as a grassroots program manager in the public policy department. Since then, he has been the Associate Director for Public Policy at the National Association of People Living with AIDS. He was a lead organizer working with Equality Maryland to achieve passage of the Baltimore Transgender Anti-Discrimination Ordinance. Stayed on as the interim director and then became the Director of Transgender Outreach, and is currently the Sexual Minorities Program Manager at the Center for HIV STI Integration and Capacity at the Infectious Disease Prevention and Health Services Bureau, Prevention and Health Promotion Administration at the Maryland Department of Health and Mental Hygiene. Among other responsibilities, he provides capacity building training and technical assistance to improve HIV prevention services for LGBTQ communities and people living with or at risk for HIV. He sits on several community advisory boards for current HIV research initiatives, is a co-founder of the Transgender Action Group, and the chair of the Transgender Response Team. How'd I do?
Yeah, that was amazing.
And then also with us is Dr. Tonia Poteat. She is an assistant professor in the Department of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. She received a Master of Medical Science degree from Emory University's Physician Assistant Program, a Master of Public Health from the Rollins School of Public Health at Emory, and completed her PhD in International Health at the Johns Hopkins Bloomberg School of Public Health. She has been working in the field of HIV/AIDS since 1989 as a volunteer when she was in college, and she has been an activist, a clinician, a public health official, and a researcher. She is a leader in public health and research efforts to address transgender health disparities and has multiple publications on stigma, barriers to care, and the disproportion of HIV faced by transgender individuals. In 2016, she gave the first plenary at CROI, which is the big research conference on retroviruses and opportunistic infections, the first plenary on HIV in transgender populations. She is currently supported by the Hopkins Center for AIDS Research to conduct a study of HIV vulnerability among transgender women of color in Baltimore toward the goal of developing feasible and acceptable community-based HIV prevention interventions. And she also provides medical care for people living with HIV in the war. So we are very honored to have you here to speak with us about providing safe, affirming, evidence-based care for transgender persons. We plan to do a series, so this is the first of 3 talks. This will focus on the basics.
All right. Yay! Oh, thanks so much. Is this working? I can't tell.
Only for the recording.
Oh. Okay, so it's not. All right. So am I blasting you out?
No.
Okay. Because I have been known to break microphones. That's what happens when you put an old street organizer on a microphone. We don't really need them. So thank you all so much for coming today. I also would like to thank Joyce for inviting us to speak. And I would like to thank Tonia for the very last minute agreeing of, yes, I'll join you for that. So thanks, everybody. Let's go ahead and get started then. So we thought that we would try to come up with some very basic objectives today. We would like to lay a foundation for a continued dialogue throughout the series of talks that we're planning on doing. And our plans at this point are actually very open. We would like for you to help inform us of what these talks should include when we get to the end today. So there'll be time to chat and tell us what else it is that you would like to know. But basically today, we hope that as a result of participating in the talk, you'll be able to recall some terms and definitions. You know, you'd be able to be more familiar with the language of transgender lives and experiences and of some of the terminology that may not at this point be familiar, but would be helpful for you to know when you're working with your clients. Also that you'll be able to have a better understanding of some of the health disparities that affect transgender populations so that you can be on the lookout for how your clients are faring in their overall wellness and whether or not any of these disparities seem to be online for them. And then also to identify some best practices. It's always helpful to have a shortcut list of things that you can do, particularly if you find that your visit isn't going terribly well. It's nice to know how to get back on track. So we want to be able to share some of those with you. So that's our agenda, and there should be copies of that going around, so I don't think we need to look too much at that. So let's talk a little bit about some of our words and definitions. Now, I often find when I'm talking to people about transgender people and about just LGBT people in general that there's a lot of confusion between sex and gender and the role of sexual orientation in that. Part of that has to do with the way that we simply conflate these ideals in our daily lives. We don't really grow up talking a lot about sex or sexuality. We don't really examine a lot about gender roles. We just simply adopt them and carry on until something doesn't work. And then when something doesn't work, we begin to question what's going on. So it's important to be able to understand that there are these three very distinctive parts of human life. And while everybody has all three, they are not dependent on each other. They do not necessarily inform each other or control each other. So the first is your biological sex. This is how your body is made. This is like sort of the things that you can actually touch, you can grab and hold on to. You can grab yourself, but don't grab your neighbor unless you have permission. Sex is really all about what chromosomes do you have? What's your karyotype? Do you have XY? Do you have XX? Do you have XYX? What do you have? What's going on in there? What's your blueprint say about you? What sort of external genitalia do you have? Do you have a penis? Do you have testes? Do you have a vagina? Do you have ovaries? What's going on? What reproductive organs do you have? And then what happens to you during puberty? What are the secondary sex characteristics that you develop? You know, do you develop breasts? Or instead, does your Adam's apple thicken? What sort of goes on with you? So these are the sort of the hard facts. It's your biological identity. Gender, on the other hand, has nothing to do with how your body is built. This is really your psychosocial identity. This is how you interact with yourself and the outside world on a daily basis. This is your sense of identity. Do you see yourself based on your society's cultural norms as a man, a woman, maybe a mixture of both, or maybe neither at all? What is it that you see yourself as? What gender roles seem right for you? What feels like the right thing to be wearing? You know? How you express your identity to other people. What clothing do you wear? You know? Sometimes when I do a presentation when it's not 500 degrees outside, I've been known to wear a tie. My tie is sort of my signal. It's like the, hi, it's a tie, I'm a guy. It helps people kind of remember, right? So your clothing is a signal to other people on what your gender identity is. Whether or not you're wearing makeup, how you carry your body, how you inhabit space. We are socialized as children within these different gender identities and roles on all of these different things. We think that they're very natural to us, but we've actually learned a lot of them through our growing years. And then finally, attribution. What do other people see when they look at you? Because we all know what the gender rules are, we tend to treat people based on what we perceive their gender to be. Right? If you ask people through many different sort of social science surveys, who's more approachable, men or women? Most people say women. And the reason that they say that is that they have been socialized to believe that women are non-threatening. Whether that's true or not is a different thing, but that's our socialized belief. So we behave differently to people based on what we think their gender is. So if your gender is in question, people may have some difficulty relating to you if they're not seeing very clear signs. This is one of the reasons why people sometimes are misgendered, or the person perceives them as male, but actually they identify as female, or vice versa. Is that making sense? All right, that's the hardest thing to remember and the easiest thing to forget. So let's try to remember that throughout the rest of the day. When we look at some of the different words, transgender, we've all heard that word a whole lot. But what does that really mean? The first thing I want to say about words is don't get hung up on them. English is an amazing language. English adds more new words to its language every year than any other language on earth. We've added things like cyberpunk. I imagine that by next year in the Oxford English Dictionary will be Pokemon Go. It's going to be part of language because we popularize things very quickly, right? So the language around transgender lives and experiences also continues to change. So don't get hung up on terms, just kind of look beyond the terms to the meanings. So a transgender person is basically anyone whose gender identity differs from the sex that they were assigned at birth. So if you were identified as a male at birth, but your internal sense is I'm a woman, and you live your life that way, and you take on those gender roles, then you're a transgender person. Does that make sense? Okay. You can also be gender nonconforming, which means that perhaps you don't fulfill the ideals of the gender role that you were assigned. We find a lot of people who are lesbian or gay or bisexual are not gender conforming. You'll find gay men who are perfectly fine with putting on some eyeliner, you know, or perfectly fine with maybe using a material in some clothing that is typically used in clothing for women. But they don't identify as women. They're not women, they're men. But they're gender nonconforming. They don't conform to the rules of their gender. So it's different between being transgender and gender nonconforming. Gender nonconforming is about sort of tweaking the role to suit you. Being transgender is your identity has told you that that role is not right for you based on your gender. Do we see the difference here, or do we have a question? Oh, I think we see the difference. Okay. And then cisgender. Cisgender is basically somebody who's not transgender. It's nicer to actually have a word and not say that people are not something, because that's really rude, really. So cisgender basically means that your sex assigned at birth and the current gender role you inhabit and your own sense of gender all agree and they match. Trans meaning to go from one place to another, cis meaning to stay in the same place. So that's how those two things work. These understandings have created something called the binary gender model. The binary gender model is everywhere. It's the reason we have 2 bathrooms. It's the reason why we have 2 different kinds of bicycles. And if you think about why there are 2 different kinds of bicycles, one with the bar across and one with the scoop, you might wonder, why did the guys get the one with the bar across? Anatomically, this does not make sense. But apparently the scoop was to accommodate these very large dresses that women wore when bicycles first came out into the world. So it was really about pants and skirts more than it was about anything else. It's also the reason why we have color choices. Pink is for girls and blue is for boys, right? So we've sort of set up our entire world around this idea that there are 2 different genders, and only 2, and that they are the polar opposite of each other, and that they must be somehow treated very differently. So in this sort of social math that's done around gender, you know, if you are identified as male at birth, you're expected to then identify yourself as a man. I'm a man. And you're expected to have an expression that's masculine. You know, you like to drive that big truck in, you like to go on down to the football game, and you eat a big old messy burrito, and, you know, talk trash with your buddies. That's one way to be a guy, I guess. It's not how I'm a guy, but no greasy burrito for me, please. And then you're expected to be sexually attracted to women. So that's sort of our expectation. If you're identified as female at birth, you're expected to identify yourself as a woman, to have a feminine expression, you know, wear those cute little clicky-clacky heels, put on some pretty makeup, perfume yourself, right? Be all really sort of tee-hee-hee. Yeah, that stuff still exists. I'm always scared when I see that, but it exists. And you're expected to be attracted only to men. So that might be true of a lot of people, right? But you've seen where that binary model actually works for people, right? But does it work for everybody? No, it's not true for everybody. The problem with the model isn't that it's a model and it's not true for everybody, but because we sort of depend on these things without questioning them, we then end up with all of their products. And one of the products of that model is that it assumes and reinforces and privileges cisgender identity. So if you don't fall down that line and fit in those boxes and you're outside, you experience a lot of different things. You'll experience stigma for being different. You'll experience discrimination, sometimes intentionally and sometimes just functionally. You know, how many people have seen in the news that transgender people in many states have to worry about what bathroom they can use? Right? Think about that. If you're a cisgender person, you never have to worry about that. You can just go to the bathroom that has the little symbol that you identify with. Right? You don't have to worry about that. You don't have to worry that you'll go into your practitioner's office and try to fill out an intake form that won't have the right language, or that will have your body parts in one column that is not the other column that suits your identity. There are just things that don't really work. And you sort of suddenly find yourself in a way where you're not able to function very well in a society that's built on this two-gender norm. It also assigns and distributes these different roles. And there's something about when people don't fall into the predicted norm that it causes us to be uncertain about what we should do. How should I, interact with this person who's not behaving in a way that I anticipated? It sort of throws people off their dots, right? It also invalidates any identities that don't fit within those boxes. It invalidates transgender lives. It also invalidates intersex lives, who then have additional sets of challenges, including, genitalia that may not match what their practitioner is expecting when they come for a visit. And it also means that you're not fully equal because you can't access the way that we have created equality. Because it's created only based on those two genders, it's really hard to access if you're transgender. So here's a different way of looking sort of at the three different things put together. So let's suppose you have someone who is identified as male at birth. So this is someone who has what we consider to be the typical, male body parts, right? And this person identifies as bigender. What do you think bigender is? Anybody? Sing it out. Exactly. Exactly. The giveaway there is bi meaning two, genders, so two genders, right? Perfect. Thank you. So they identify as bigender. They have a feminine expression. And this person is attracted to other women. So that's one way to be. Or maybe you are identified as intersex at birth. Now, there is about 3,000 ways to be intersex, so we don't really need to figure out which way that is. But this person was identified as intersex at birth. And their identity is as a man. That's how they identify. That's how they experience themselves. They have a masculine expression. They're out driving that truck. And they're attracted to other men. So that's another way to be. Or someone who's identified as female at birth who has a non-gender identity. Think for a moment what it must be like in a society where everything has a gender except our language. At least we don't have romance language that has a gender, right? So everything has a gender, but you don't. It's like everybody else saw a movie that you never saw. And they're talking about it, and you're like, what? I don't get that plot. I don't understand the plot. It's having an absence of any sense of gender internally. So that's kind of hard to wrap your head around, right? Especially if you have a very clear sense of gender yourself, trying to imagine what it's like to have an absence of that feeling. And this person's expression is neutral, which kind of makes sense, right? And this person is attracted to both men and women. So we get really hung up on all these different labels: gay, lesbian, bisexual, pansexual, omnisexual, scoliosexual. Can I please have some sexual? Demisexual. And there's lots and lots of sexual. We get hung up on all of these labels. The reality is people are really, really complex. A friend once told me, people are messy. And what she didn't mean like my daughter's room. She meant people are messy in that they don't fit neatly into different boxes and columns. They're all over the place because we experience life on a moment-to-moment basis. And sometimes we do so in a very unpredictable way. So, you know, let's not get hung up so much on the language. Let's remember that what we need to know about it, but also internalize that your clients are complicated people. They're whole people, and so they're complicated. They have a lot going on. So when we talk about some gender grammar, oftentimes you will find that maybe you're having a conversation with a transgender client or even a transgender colleague, and you say something and you notice that it maybe didn't go over so well. There was like a little thing, like maybe the person sort of shuddered or blinked. Something about their body language let you know, oh, that didn't really work out so well. It's because we're not familiar with the language yet. So there's lots of people with lots of words who don't quite know how to use them yet. So let's talk about a few. So transgendered with the ED. So let's not use that. Transgendered is actually an adjective in and of itself. It did not derive from a noun. We never want to use transgender as a common noun because it's sort of like using cat or dog as a common noun. So instead of transgendered, which infers that something happened to the person, transgender is an adjective that describes something about the person. Transgendered as in terms of transition. Some people have not heard the word or the term gender transition yet, but that would be the appropriate word to use when you're talking about someone who was perhaps identified as female at birth who's moving towards a male gender identity, or someone who was identified as female at birth but is moving towards a sort of bigendered identity. This is the process is called transition. We never want to use transgender on its own, like I said, as a noun. We use it with transgender person, transgender woman, transgender community. So transgender describes the other word that you were using. And there are a variety of words to express the idea of someone having a surgical procedure in order for their body to more closely match their internal sense of gender. It's variously been called sex change or gender change. It actually is gender confirming or gender affirming surgery. You actually can't change someone's sex with surgery because we can't get down to that level. The only thing that happens is the body and the genders now start to match more. And that's why people do that. Pronouns are important. Pronouns are full of stuff. They're full of history. The history of even why there are pronouns is very interesting, but we don't have time to listen to that. So we're familiar with the binary pronouns, she and her and him and his. We're familiar with that. But there are some other pronouns. For example, they, them, and theirs. Anyone who had like a minor in English is going to go crazy with that idea. I really understand that. I was an early reader, so I really got stuck on how English is composed. But yes, there is a possibility to have an individual or a singular they, them, and theirs. So some people use that as opposed to she or he, right? So I like a friend of mine actually came up with that sentence. Zena ate their food because they were hungry. She liked Zena. Remember Zena? Zena was fun. Yeah. Or Z and here. Not quite as popular as they, them, and their. You might find younger people are more likely to use Z and here. But they're used like this. Zena ate here food because Z was hungry. Or, have you seen Molly? Yes, I saw here. Z was at the movies with Ralph. Yeah. It's a challenge, right? It's a challenge to learn a new thing. But at least they're short. They're not like some of those medical diagnoses that you have to give out that are like 15 letters long. So at least they're short. Or some people just say, hey, you know what? I don't use any pronouns at all. Just use my name. It's okay, just use my name. So instead of saying Zena, she, Zena, here, just Zena. I saw Zena's car in the parking lot. It's kind of easy, right? So it's really important for us to recognize, and I believe this truthfully, that most medical providers are medical providers because you want to help people. Not because you want to be fabulous, not because you want to make $1 billion, not because you want $1 billion in debt. Hello, how much does it cost to become a medical professional? But because you want to help people. So it's incongruous that you would then be insulting to people. So I don't believe that people do these things intentionally. I believe that it's all a mistake of communication. But it's important to remember that while your intent may be really good, the impact on your client may not match your intent. So you might be using words or conducting yourself physically in a way that works for everybody else, and you're wondering, why is your client sort of now not talking to you, not looking at you, not responding to you? Because you are not aware of anything being off. So it's just sort of, elevate your sense of what's going on, sort of step back a little bit and watch what's happening between the two of you to recognize that maybe your intent was good, but the impact kind of went the wrong way. And then you're going to learn about some things that will help you recover from that. And this is probably one of the worst ones of all. It doesn't seem like it if you're not transgender. I get that. But if you're transgender, being misgendered is like this big weight that you're forced to take on every time somebody does it. In a way, it's like trauma. It's like psychological trauma. It doesn't go away unless it's dealt with. It just builds up. So if everyone gave you a 5-pound bowling ball to carry, pretty soon you'd have a hard time carrying all those bowling balls. Being misgendered is like having a weight put on you. So if your client got misgendered 17 times before they got to your visit, they've already arrived with this thing that's weighing them down. And then if they get misgendered at the reception desk, if they get misgendered in the hallway, and then if you're misgendering them, it's just all too much. So misgendering is just simply using the wrong pronoun. So you want to ask people affirmatively what pronoun they want you to call them. And it doesn't have to be written down anywhere. It doesn't have to be part of their permanent medical record if they don't want it to be. But it should be one that you actually know what it is and that you use it consistently. Does that make sense? Yeah, I knew you would understand. So now I have the pleasure of turning this over to Tonia, who's going to talk to you about HIV disparities in transgender populations. Let's get on flipped here. Can you see?
Yeah, I think I did that to you. Okay, let's do it back to myself. Thanks.
Oh, thank you.
Just take that.
Yay!
Hi, people over the other side of the computer. We actually blended the presentation, so we're kind of going to go back and forth. And feel free to clap every time anybody stands up or sits down, because it's really nice and affirming. Okay. I feel like every day I wake up, there's a new article about transgender health, either in the popular media or in the scientific literature, which is great, actually, because there were many years where you could open up the literature and see absolutely nothing. So for those of you who were at the CROI talk, I gave a number on how many transgender people there were. And then, of course, 5 seconds later, just like, you give an HIV talk, and then, like, the new guidelines come out the next day. So it's the same thing. So soon after that, there's new data available on how many trans people there are. And it makes me very excited, because that's usually one of the questions people ask when they say, oh, you do research on the health disparities of transgender people. How many people are that? Aren't there only like 2 trans people in the world? And so now I get to say no. Actually, we think there's about 25 million trans people in the world. So that's the latest estimate from The Lancet that was published in July 2016. The estimates of the percentage of the population varies by country and how the studies were done and which studies were done, but somewhere between 0.1 and 3% of the population, depending on the study sample. If we look at the United States, there's also a recent update to the estimate there. So I used to say for many years 0.3% of the population. So now that was based on studies in 2 cities. So now the latest data is from surveillance from 25 different states in the United States. And it looks like it's closer to 0.6% of the population, so about 1.4 million people in the United States. And excitingly, this is your preview of Baltimore estimates. One of the studies that Jean-Michel and I are working on together is a needs assessment of the trans community here in Baltimore. And one of the things that we are trying to figure out is how many trans people are in Baltimore. Because if you're going to provide adequate services, you want to make sure you know how many people you're providing services for. So we used one method called wisdom of the crowd, which I absolutely love and we'll talk to you about for hours afterwards, where you just ask people how many people they think there are, and then you take the median. And people are estimating about 12. This actually works. It's sort of like the tipping point. It actually works. And then we use the service multiplier method, which we can also talk about later, saying about 912 people. So somewhere around 1,000 trans people in Baltimore City itself. This is a slide pulled out of part of the Lancet series on transgender health that came out in July. So some of you might have seen it before. And I provide it here because Jean-Michel talked about gender affirmation in the medical sense, but there are many ways that people affirm their gender. There's social gender affirmation, so that's you using the correct pronouns with the person and them being able to get identity documents that match as a legal form of gender affirmation, psychological gender affirmation, knowing inside who they are, and then medical, like we've already talked about. So I wanted to make sure that we knew that there were at least 4 different ways that we can talk about gender affirmation, and that you can make me be more precise if I'm not being precise when I say gender affirmation. Oh, that doesn't project very well, does it? No? Okay, well, we'll just talk. So not everybody who falls under the transgender umbrella, so that definition that we provided, actually likes the term transgender and wants to use it for themselves, right? So sometimes when we do studies or when we're seeing clients, we think we can have a checkbox that says male, female, transgender, and then that will tell us how many people are transgender. And in fact, that's not true because people don't always identify with that term. So the Center of Excellence for Transgender Health at the University of California, San Francisco, has tested a 2-step method that seems to work pretty well, where you first ask people what their current gender identity is, and you give them a series of options depending on where you're doing your work and what the most popular terms are, and you see some listed there. And then you ask them what sex they were assigned at birth. So if the person identifies themselves as transgender, then they can fall under the transgender umbrella. Or if the sex they were assigned at birth is different from their current gender, then you can make that estimation that the person is transgender. And what you see on the right of that slide is this 2-step method versus a 1-step method that was done by the Centers for Disease Control when they looked at their HIV testing data. So they used to just ask the "Are you transgender?" question. That's the 1-step method. And you can see when they went to the 2-step method, they saw a large increase. Oh, this didn't project very well out. A large increase in both the number of transgender people who were tested and the number of transgender people who were positive. And in fact, the proportion of change was greatest for the number of transgender people who were positive. So if you're not asking the 2-step question, you're missing a lot of people. So this is also testing data from the Centers for Disease Control and Prevention that looks at new HIV positive tests. So the caveat to this data is that it's testing events, not individuals. And it's not necessarily people who are newly infected, it's people who are newly tested positive. Okay? But given that, when they looked at their testing data, after having used the 2-step method, they found that the proportion of new HIV positive tests were highest in transgender people. So 2.4% in trans people and 0.9 and 0.2 in cis males and females. The gender trajectory actually mattered, so you can know whether or not somebody's transgender, but knowing if they're transitioning along a masculine spectrum or a feminine spectrum really matters, because people who are transitioning along a feminine spectrum are much higher risk for HIV and had a much greater likelihood of having an HIV positive new test. And then within that group, it's highest among trans women of color. This is not a surprise to many of the people in this room. What I thought was really important was that also if you look at the data, does my arrow show up? No, my arrow disappeared. I did draw an arrow on the side, so I'm going to walk over and point to this area right here. So we're looking at trans females, and we're looking at the percentage of new HIV positive tests. And you can see the bar goes from low to really high. And if you look along the bottom at what the colors mean, it's right between the ages of 19 and 20, right? So when we talk about doing HIV prevention work for transgender women of color, we can't talk about doing it for people who are 20, 30, 40, 50 years old. We have to talk about doing HIV prevention work for people who are very young. So that's important too. A lot of the talk is going to focus on HIV among trans women because that's where we have the most data. I think there's very limited data on HIV among trans men. What we do have, as you can see, ranges from a low of less than 1% to a high of between 4 and 5% of HIV prevalence among transmasculine or trans men. With the caveat that in those studies where you see a 4% HIV prevalence, that typically is a study with a very small sample size, where there's like 25 or 30 people in the study, so that 4.3% represents one person. So we don't have really large population-based studies, and the ones that we do have from the CDC show less than 1%. Even though that is true, it is also really important to keep in mind that trans men who have sex with men are men who have sex with men. And we know that there is a high prevalence of HIV among men who have sex with men. And it's important when you're seeing trans clients not to go, oh, that's a trans man, he's at low risk for HIV, but really to understand what is his sexual identity, what is his sexual behavior, and assess then his HIV-related risk. Anything to add to that? Okay. So most of the rest of what I have to say in terms of data is related to trans women. Colleagues and I here at Hopkins published a meta-analysis that was in The Lancet in 2013, and we looked at global HIV prevalence among trans women. But when you look at the data from the United States, the prevalence was 22%. Right, so all of you know that that's incredibly high, that the prevalence of HIV in the United States overall is less than 1%, so 22% is incredible, 34-fold higher than the general population. We recently did an update to that with the synthesis of the data. And we tried to parse down just like where are we seeing in this sort of global trans women, where are we seeing the highest prevalence of HIV? And we see it, not surprisingly to you, among trans women of color, and we see the lowest among youth. So even if you look 16 to 24 years old, you still see 4.5%, which is much higher than the less than 1% in the general population, but hasn't reached the 22 to 40% that you see otherwise. And then if we look at trans people who are living with HIV, there are questions about how well are they engaged in care. I'm sorry for the projection. I think I'm not fancy with PowerPoint. But this data is taken from the Ryan White care data from around the United States. And when they published the data from 2014, they found that a little over 5,000 people in the Ryan White program are transgender. And you can see on your left the breakdown by race. And not surprisingly, just like the population of people living with HIV in the United States in general, the vast majority are African American, and with the next largest being Hispanic or Latino. And then they looked at how well are trans people engaged in care compared to other people who are not trans. And on the left, you'll see the tall bar, 81% is overall the Ryan White population, number of people with viral suppression, and then 74% among transgender people overall. So lower, not surprising. What is dramatically lower, though, is if you break it down by age. If you look at young transgender people living with HIV, a little over half are actually virally suppressed. And it's comparable to having unstable housing. And we know how unstable housing really is a barrier to being engaged in care and reaching viral suppression. So being a young transgender person also confers that level of risk of lack of viral suppression. So what about Baltimore? So what I'm going to present you is old data. It's from 2004 to 2005. That's what we have right now, with a little caveat about an update for the study that we're doing right now. But back in 2004, 2005, Jean-Michel was involved in this, and he can jump in and tell me if I'm not representing it correctly. But Be Sure was doing their annual surveillance. So people who are familiar with Be Sure know that they do HIV surveillance every year with different populations. One year they do MSM, the next year they do people who inject drugs, the next year they do high-risk heterosexuals, and then around again to men who have sex with men, and an ongoing cycle. So this particular year was a survey where they were looking at HIV prevalence among men who have sex with men. And people from, I understand people in the trans community are like, we need to be included as well. We don't have any data on HIV among trans people. So transgender women participated, and there was also an additional supplemental questionnaire that was added for transgender people to complete. But for people who know about studies and study design, so some people did the routine study, some people did the supplemental study, some people did both, but most people did one or the other. So we end up with sort of two data sets. In the Be Sure data set, there's 49 trans women, and then the Baltimore supplement, there's 40 trans women, and there's an overlap of only about 2 or 3 people, so I'm going to present them as 2 separate data sets. So what we saw in the Be Sure data was a prevalence of 42.5% here in Baltimore City. For the people who completed the supplement, the prevalence was 33%. So whether it's a third or four-fifths, it's still an incredibly high prevalence here in Baltimore City. And of those people who had HIV, 64% of them or 65% of them did not know they had HIV at the time that they were tested. So these were newly diagnosed people with HIV. Now, this is what, 10 years ago, so we're hoping to see something different. What's going on right now, I don't have a slide for this, is that the CFAR has kindly supported the study that we're doing among trans women of color here in Baltimore City to try to get an updated estimate of HIV prevalence and to get some more trans-specific appropriate information about what are some of the drivers of that high HIV prevalence. What are things that are in the structure of our communities? What are things that are in how people behave? What are other factors that are related to this elevated risk, so we know how and where to intervene. So that is ongoing right now. I can tell you, though, that unfortunately, at this point, we're halfway through data collection, and we have an HIV prevalence of 60%. So, well, I spend a lot of time talking about prevention. I think we also need to spend, and obviously you're the people to do that, a lot of time talking about making sure people are engaged and have access to care. Okay, so here are some of the things that we do know about why there's such a high HIV prevalence among transgender women of color in particular. There was a national study looking at discrimination against transgender populations in the United States. The data was collected around 2009, and it was published in 2011. And I'll summarize it overall just to say a whole lot of people get treated really badly in the United States. So they found that 63% of the people surveyed had experienced job loss or eviction, bullying in school or harassment, physical or sexual assaults, being kicked out of their homes because they were trans, losing a relationship with a partner or a child, being denied medical services, or being incarcerated. And I was surprised to see it was only 63%, to be honest with you. I think the majority of people have had some sort of stigma or discrimination experience, and maybe they don't necessarily want to label it as such. About a quarter of the people who completed the survey had what they called catastrophic levels of discrimination, meaning had experienced at least 3 or more of those events at the time that they completed the survey. We also know, I pull these from Baltimore in particular, that there's a lot of violence against transgender women. The National Coalition of Anti-Violence Projects publishes data every year on violence against LGBT communities, and every year, for as long as I can think back, there's been higher levels of violence against trans women of color in particular compared to all other groups. And we see that also here in Baltimore. And I think one of the painful things is that not only do we see this high level of violence, but we see this high level of violence with impunity. So rarely is anybody charged, rarely are people convicted, rarely are people held accountable for that violence. So to continue with our depression tour, we're going to talk about trans discrimination in Maryland. So in the national survey, there was specific data from Maryland from about 132 participants out of the almost 7,000 people. Even though there's been a non-discrimination ordinance in Baltimore City since 2003, there wasn't an ordinance for the state of Maryland until 2014. And the study was done in 2009. So they found that 71% of people had been harassed on the job, 42% had been fired, not hired, or denied a promotion because they were transgender. 80% of people reported being harassed in school, some were assaulted and experienced sexual violence at school. Over half were verbally harassed or disrespected in public places, and 43% reported attempting suicide at some point in their lives. And this is more than 26 times the rate of the general population, which is around 1.6%. I think it's disturbing that 1.6% of the general population has attempted suicide, and I find it unconscionable that 43% of trans people have attempted suicide. And those are the people who were, of course, alive to tell us about having attempted to commit suicide. So in 2011, as part of my dissertation, I did qualitative research with people in the trans community here in Baltimore and asked them to complete a stigma and discrimination scale. And I asked them some of the same questions that overlapped. And what people had to say in 2011 is that still 50% of people had trouble getting a job, 40% of people had lost a job, and over 3/4 of people had been verbally abused or harassed because of their gender identity or expression. But I have the little arrow pointing to 23 there, even though it's not one of the highest numbers on the chart. That's still almost 1/4 of people who have trouble getting medical services because they're transgender, and that's right here in Baltimore. in our community. So not a surprise, I'm talking about these because stigma is a barrier to care seeking. We know that people delay getting health care if they either have experienced discrimination themselves or they anticipate experiencing discrimination. And I think we can send you a PDF of those slides if you want these exact numbers. I just want to make sure that we have time to get through everything. And we know that stigma is a barrier to care provision, right? We know that some people are denied medical care outright because they are trans. We know that about half of trans people who were surveyed reported having to teach their healthcare providers about how to take care of them. And I find that frightening because I just had to get my car fixed, and if the mechanic had relied on me to tell them what to do with my car, I would be walking to Baltimore. That's what would be happening. So we don't want people to have to do that. And then, saddest of all, people experienced discrimination from their healthcare providers, either having people refuse to touch them, blaming them for their healthcare problems, using harsh or abusive language, or even being physically rough. So that is the end of the Depression tour. I think the next half we're going to talk about what are some of the positive things that are happening in response to all of this data that we have around stigma discrimination and around HIV and trans communities. I don't get applause? I was like, I need my applause.
Okay, let's see. Okay, I hope that's working. All right. So I thought it was important to have a little bit of a dialogue around identity documents. This is also something that many transgender people, many cisgender people don't have to ever worry about. You can easily go to a state agency or a federal agency and get an identity document that reflects your correct gender and name, as long as you can afford to pay for it, right? So in Maryland, we recently had an update to how birth certificates are handled in terms of new additions to birth certificates. So previously, you had to have a sworn statement from a physician saying that you had had gender reassignment surgery. No longer do you need to have that, which is really good. So instead, you just need a sworn statement from a doctor that basically says you've completed gender transition. You've been through the process, whatever that means. It could mean you took some hormones. It could mean you took some hormones and had some kind of surgery. It could mean you just convinced the healthcare practitioner that you have lived in this gender all of your life and you're done. It doesn't really require a specific kind of treatment. Or that you've been diagnosed with an intersex condition. So then you send that off with an application to change your gender marker on your birth certificate, and you actually get a brand new one, not a revised one. And it's really important to get a brand new one, because if you get a revised one and you have to show that in order to get other ID, or if you have to show that for other things, then it sort of busts you, right? You don't get to keep that part of you private. So that's a really good thing. We can thank the good folks at Free State Justice for making that happen. Driver's license in Maryland, we've had a process for a good 15 years, I want to say, where you can get a provisional license with a change in your gender marker. And it just simply requires 3 letters. Notice I say it simply requires 3 letters. One from you, one from a doctor, and one from a psychotherapist. And both the letter from the doctor and the psychotherapist basically say that you're under treatment, you have gender dysphoria disorder, and you need to have an ID that reflects the gender that you identify with in order to pass something called the real life test. Now, these are based on the World Professional Association of Transgender Healthcare Standards of Care. And so you send that off and you pay the fee, and it goes to the main headquarters down in Glen Burnie, and there's a medical board that meets once a month, and they do things like, let's say you had epilepsy that was under control, was not under control, and you'd lost your license, right? Because that can happen. Or you had diabetes that was not in control and you had lost your license. And now you're reapplying for your license with a doctor's note that says that your epilepsy or whatever medical condition you have is now under control and you haven't had an event for 6 months, et cetera, et cetera. So those would go to this medical board. So it goes to the medical board, and if everything has been filled out correctly and they ate a good lunch and the air conditioning is working, whatever, then they will say, okay, fine, that's approved. And then you'll get a letter from them inviting you to come on down to take your picture and get your license. And then that license is good for however long a driver's license is good for in the state of Maryland, which is usually like 6 years, I guess. Oh, my word. Okay. So in any event, if at the end of 6 years you have not completed transition, meaning that you've had gender reassignment surgery, you have to go through that application process again. Otherwise, your license reverts back to the previous gender. So it makes more sense to get your birth certificate fixed first than go and take your birth certificate down to the MVA and get your driver's license reissued with the new birth certificate. U.S. passport also is easy, but costs money. It's $150. Social Security record doesn't cost anything, but it requires that you've pretty much done everything else on the list before you get to Social Security. And so the reason that I show you this is that while it's possible to do those things, it also requires a lot of access to people and resources and money. And so for many transgender people who have the highest rates of living in poverty, based on the national survey, than anybody else, these are distinctive challenges. And it's probably why you're going to see transgender patients who have ID in various stages of name or gender change. So I was notified that we only had 2 minutes left. So I'm going to actually skip all of this, because you're going to get the rest of these slides, right? And I would like to go to the, is that okay with you, Tonia? I want to find out what you want. There we go. I have the question. So come on up here, Tonia. Don't make me be alone. Please don't make me be alone. Tell us, please don't make me. Tell us what it is that you're interested in including in the next 3 talks. Yes.
Copies of, copies of what the forms look like for transgender persons to get their IDs and birth certificates and stuff like that changed. Just because I know we at Harry Lane we work with adolescents, so I mean we may have some that are interested in changing over their information. So just to have that, so that we can get more information to give them, so they know the process.
Okay, so samples of forms for changing identity documents. Okay, what else? Yes.
Like the clinical update we talked to Tonia about in terms of doses of estrogens, how you manage, how you follow, issues around sometimes prior authorization, some of the tricks of the trade as well as the clinical.
That's great, because it's a changing landscape that we didn't get a chance to talk about for coverage.
Yes.
I think trans-friendly providers here at Hopkins, so endocrinologists, OBGYNs, therapists, just Hopkins-specific providers who not only trans-friendly but LGBT as well.
Okay, LGBT-friendly providers here at Hopkins. Okay, yes. That would be great?
Prep.
Oh, PrEP. Okay.
Suggestions for working with other staff members, the front office, your security folks, your greeters, your billing specialists, reaching out further into your clinical environment to create a fully welcoming place.
Okay. How to work effectively with their colleagues so they will be as awesome as you. Okay. Yes.
Primary care for
Okay.
prevention, holistic approach.
All right. primary care, prevention, and holistic approaches. Oh, thank you.
I'm the OBGYN, so I think some of the particular clinical issues that trans women face, besides issues related to HIV, talk a little bit about decision-making around surgery. I've seen a number of trans patients where that is a huge issue and is approached very differently.
Okay, so some of the clinical issues that are you looking for them just particularly related to OBGYN or more broadly?
Well, probably more broadly.
Okay. Okay, no, it's worth asking. Okay, more broadly. And then how people make decisions about what surgeries to have and when and, okay. Anything else? Yes?
I'd like to hear a little bit more about some of the health disparities that we're talking about in terms of homelessness or poverty, some of the other things that affect what providers can do or resources that providers can access to help persons with trans experience.
Okay. Health disparities around particularly issues around homelessness, some of the other impacts, and resources that providers can tap into to help provide referrals for that. Okay. Anything else? Yes?
I'd like to know what systematic changes are in progress at Hopkins to conform to any of the best practices that you guys have.
I got you.
Okay, what's going on at Hopkins in order to come up to par with some of those best practices that we're going to recommend? Yeah. No one hiding behind the monitor? That's it? You've been awesome. Thank you so much.
I just want to add that I'm here, and you can search for me in the email chain. So if you have other things that you think are important and you're too shy, or you think about, if you're like me, you think about everything as soon as you leave the room, then please just email me and we can add it to the list of things, okay?